All right, so now we're going to begin our discussion on chapter 13 from EHDC, Neurologic Diseases and Conditions. So overview of the nervous system, right? What does the nervous system do and what is it composed of? The primary cell is the neuron, right? These are these cells that actually communicate nervous impulses. They communicate information between each other. They are excitable cells. Nervous system also has microglia, things like your dendritic cells. You're going to have your Schwann cells that are associated with myelination, and all these other types of cells that exist and have very specialized functions to support the neuron. Structurally, neurons kind of bundle, their axons kind of bundle together, and you get nerves, right? When a bundle of cell bodies exists, that is when you get something called a ganglia, right? So ganglia lead to nerves, and those ganglia and the nerves that come from them are typically associated with specific functions. We also have the spinal cord, which is the key part of the central nervous system for communicating directly with the rest of the body. The spinal cord is kind of like a highway, taking information from all of the small towns, like you can think of the different pieces of anatomy in your body as like a small little town, and it communicates with the big city of your brain, right? We have the two primary divisions, our CNS, PNS. Our central nervous system is just the brain and spinal cord, and everything outside of that is peripheral nerves, okay? And that includes your cranial nerves. Even though they come directly from the brain, they are considered peripheral nerves. Here's a quick refresher of primary pieces of anatomy and the histology of a neuron. So the central nervous system, its entire function is to process and store sensory and motor information. It governs our state of consciousness. It controls higher order thinking, like in our frontal lobe. It controls vision with our occipital lobe. Sensation is from the parietal lobe. Movement is a part of the frontal lobe in the precentral gyrus. And you've also got more complex areas like speech and speech understanding versus motor speech, right? You have Wernicke's area and Broca's area for that. And then there's auditory areas and memory, which is associated with your temporal lobe. And then you can get more complex structures that are even deeper than that. You get things like your thalamus, which is like the relay center of your brain. It would be like calling into a switchboard operator, right? That's what the thalamus does. You've got your basal ganglia, which are part of your thalamus, which are important in controlling a lot of the underlying functions of the body. You have your hypothalamus, which is almost like the part of the automatic control center of the body. You have your brainstem, which is primarily thought of as the area where the most innate tasks of all life as we know it, higher order life, live. It's where your respiration's controlled, blood pressure is partially regulated here, heart rate, all of that type of stuff comes straight, or at least partially influenced from the ganglia in your brainstem, with the vagus nerve being one of the most important cranial nerves that exists. We've also got our 12 cranial nerves. 5 of those come from the brainstem directly. These are functional areas of the brain. This is a very generic look at it, and there's actually more detailed areas, association areas that communicate and are involved in a lot of our functions of the body. So a neurologic assessment is really a step-by-step collection of data to evaluate someone's status, their neurological status, as well as their cognitive higher order functions. We're looking at things as simple as, can you feel certain sensations? Can you move certain muscles? Do you have reflexes? But then we're also looking at higher order functions. Can they understand what you're saying? Can they write? Do they have conditions like aphasia where they can't speak? Do they have even weirder conditions where they don't recognize faces. There's all kinds of fun things that can happen. The peripheral nervous system should be thought of as the way in which, information from the central nervous system gets to the rest of the body. Once it leaves the brain or spinal cord, it's in the peripheral nervous system. We have two primary ways to think of it. One is whether things are sensory or motor, which can be thought of as afferent and efferent. So sensory is afferent and motor is efferent. So the idea is you can think of the acronym SAME, SAME, sensory, afferent, motor, efferent. Then we have another way to think of the division in the peripheral nervous system, which is the autonomic nervous system, which kind of is its own separate thing. It's the automatic nervous system of the body, and that's divided into sympathetic and parasympathetic. We get a lot of glandular control from the autonomic nervous system and involuntary muscle. When we think of things like cardiac muscle and smooth muscle, those are involuntary muscle. So how do we control that? The autonomic nervous system has a major influence over those guys. The sympathetic component of that primarily comes from the sympathetic ganglia located along the thoracic and lumbar spinal cord. Just outside of the spinal cord, it directly synapses. Our parasympathetic responses in the body primarily are coming from our vagus nerve, as well as a little bit from our glossopharyngeal and a couple of the other nerves, cranial nerves, but it also comes from sacral ganglia. So the vagus nerve, which vagus is Greek for wanderer, so the vagus nerve actually influences a ton of our entire body and has tons of little branches going all over the body. It's the primary parasympathetic nerve of the body, so it has a wide range of effect, and it comes from the brainstem, which makes a lot of sense when we look at what it actually innervates. So you see here, just a quick outline of some of the key nerves of the body. Spinal nerves, you have 8 cranial nerves, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. That is in a normal person. You have different plexuses. So our brachial plexus is typically associated C5, T1, and your lumbar, or your lumbosacral plexus is L1, S3. We don't typically refer to lumbar or sacral plexuses separately like they show in the diagram. They're realistically lumped together, especially when you talk about the lower lumbar plexus, like L3 through S3. There's a lot of overlap between those guys. So there are 4 major blood vessels that supply the brain. We have 2 anteriorly and 2 posteriorly. We have on the anterior side, you have your common carotid artery, which splits into an internal and external, and you have one on each side. The internal carotid artery joins up with the brain. On the posterior side, we have 2 vertebral arteries. They run up through the transverse foramen of your cervical vertebrae 1 through 6. Only the vertebral vein goes through the transverse foramen of C7, and they originate off of our subclavian artery. Now, the vertebral arteries come up through the posterior fossa of the brain. They join together to form the basilar artery, and that is the start of what is termed the circle of Willis, which consists of that basilar artery. You have a posterior cerebral artery on both sides of the brain. You get a middle cerebral artery on both sides of the brain, and there is a anterior cerebral artery on both sides of the brain. The anterior cerebral arteries are connected by the aptly named anterior communicating artery. Now, your internal carotid artery, as we said, it joins up into the brain. Well, guess what it joins up to the circle of Willis as? It joins up as your middle cerebral artery. So the primary, what we would typically consider a terminal end of the internal carotid artery is your middle cerebral artery. Now, there are other branches of your middle cerebral artery that keep coming off, but your MCA is the most important one because that's actually where one of the first branches that come off, or sets of branches that come off, your lenticulostriate branches, that's actually where the most common stroke in the anterior fossa of the brain actually comes from. It's in those small lenticular striate arteries that end up leading to a little bit of motor loss, a little bit of sensory loss. You get issues with your face drooping. Can't lift your arm on the opposite side of the brain brain from where the stroke occurs, and the face is drooping on the same side of the stroke, right? So you end up with issues with speech as well, because those arteries supply a major part of Broca's area and a little bit of your temporal lobe. Those are the most common areas for anterior stroke. So this just shows here the autonomic nervous system. It primarily affects glandular organs. As you can see here, your circle of Willis, as we were talking about here, your internal carotid artery comes up and is going to terminate as your middle cerebral artery. If you have a stroke of the anterior cerebral artery, your anterior cerebral artery runs along that medial aspect of the brain. So you actually tend to have lower body symptoms. You tend to have issues with legs, feet, rather than arms, like we always think of with the typical stroke. You know, the person can't raise their arm and they have facial issues. You can also get posterior fossa strokes, where you could have issues with vision, more issues with hearing, understanding speech. You might also see issues with balance and coordination because of an impact to the cerebellum. And then throughout the brainstem, we have tons of other specialized strokes. You could have incredibly interesting conditions like Wallenberg syndrome and locked-in syndrome, which is the thing where people can't do anything but move their eyes, and they're essentially thought to be almost brain dead, but they can't move. So nervous system problems. Really, this is the quick and dirty list of how we can break it down. A lot of nervous system issues are a result of vasculatory and circulatory compromise, right? And we'll talk about some of those things first. Then you can have direct injury, something like a concussion. You hit your head, a concussion being essentially the most minor form. But you can also have in the peripheral nervous system, you can have compression of nerves, which produces other things. You can have like a orthopedic injury, like a disc herniation, that leads to the compression of a nerve root, which leads to radiculopathy. You can have hereditary issues. We can have congenital defects. You can have very interesting congenital defects like Chiari malformations, syringomyelias. A Chiari malformation is where the cerebellar tonsils are actually pushed through and into the foramen magnum of the skull. So that causes compression of the cerebellum. And a type 1 Chiari malformation, some people don't even know that they have it. Other people do have symptoms, and there's multiple types beyond type 1, but generally, once you start hitting type 2 and beyond, it starts to be less and less compatible with life. We can also get neurological degeneration, demyelinating disease, and then there's tumors, things like glioblastomas, meningiomas, etc. So, first thing to talk about, cerebrovascular accident. This is a stroke, right? So, we always talk about with a stroke, the acronym FAST. So, you look at the face, you look at the arm, you look at speech, and you note time. Because statistically, if somebody is the faster somebody can get treatment for a stroke, whether it's hemorrhagic or related to a blockage of blood flow, the more likely they are to successfully recover. When we look at the way that the brain pathways work, a stroke on the right side of the brain leads to left-sided body symptoms, right? So they will not be able to lift their left arm. They would have right-sided facial paralysis, though, right? You might also even see things like inability to feel pain, etc. And that's because of the way that the so-called pyramidal pathways of the brain work. They cross through the pyramids, which are in the medulla. The pyramids are just the rough grouping name for motor pathways of the body. So they cross each other, for a majority of them do, and it results in that opposite side paralysis. But the pathways for the face and head itself, majority of them do not cross. They are ipsilateral. And these are important distinctions for neurologists because it helps them localize the injury. So what can cause a CVA? Again, primarily the two main ways are hemorrhagic or embolic, meaning there's an embolism. Typically, the embolism that happens to cause a stroke is going to be from the circle Willis or one of the arteries that directly come off of it. As you start to get to smaller and smaller and smaller blood vessels, it will eventually get caught. Stroke symptoms can be widely ranging and include almost any type of neurological condition, but the big thing is fast, right? That is looking at the face drooping, speech issues, can't raise the arm, and you need to record time. Some of the risk factors for a stroke, things like high-fat diet that contribute to atherosclerosis, which we'll talk about in a later week. But fat's also not just the big thing, but people that also have diets that are high in refined carbohydrates, things that use lots of white flours, breads, stuff like that, higher insulin levels, those things cause higher insulin levels. They lead to vascular damage and inflammation of the artery itself, which can also cause embolisms to occur. There are also other diseases associated with CVA, but we'll talk about those as they come up. So treatment. It's going to depend on whether it's hemorrhagic or embolic. If it's embolic, you're going to prescribe a clot buster medication. TPA is the name of it. I forget exactly what TPA stands for, but if there is hemorrhagic stroke, they will provide medications to help slow bleeding or potentially do surgery to repair blood vessels. Again, it all comes back to how quickly you can get someone to have treatment. Strokes can kill incredibly quickly, but they can also be treatable depending on their location and size. Arteriovenous malformations, or AVMs. So these are a congenital deformity where a artery anastomoses directly with a vein where that should not be happening. There are very few locations of the body where arteries go directly to veins. There's normally capillaries between them. With an AVM, you end up typically having a very fragile structure. They're very easy to break and sever. This can actually cause essentially stroke-like symptoms in the brain. They can be very scary. I know a couple people that have had AVMs rupture. Luckily, they were, both of them that I know, they were clinicians, and they recognized their symptoms quickly, and they got help really quickly. Cerebral aneurysm. So remember, an aneurysm is just localized weakening and dilation of a wall. So in this case, it's going to be one of these cerebral arteries or veins, but it can also happen in a cerebellar artery, a pontine artery. Any artery of the body can have an aneurysm, right? The two main ones we really want to worry about, though, are if they're related to our cerebral arteries or if they're related to our aorta. Those can be incredibly fatal, especially if they are not recognized and treated before they rupture, especially if they're too large. It is possible for some of these aneurysms to get so large that when they do finally rupture, so much blood is lost that the person's dead before they hit the floor, right? So lots of things contribute to aneurysms, but the biggest things outside of congenital defects are atherosclerosis and hypertension. High blood pressure is a major driver of aneurysms anywhere in the body. Transient ischemic attacks, TIAs, these are typically referred to as like mini strokes, but the key difference here is that there's typically no imaging findings, and by the time the person is really being evaluated, their symptoms are already starting to improve. And a majority of patients don't have stroke symptoms after 24 hours. That's what separates this apart from a full-on cerebrovascular accident. Now, there are some pieces of literature that exist that indicate that patients can have persisting symptoms from TIA. I know of at least one person that was diagnosed as having a TIA, not having a stroke. They were treated within the 3-hour clinical guidelines for a stroke. They were given clotbuster due to their examination findings, historical facts, not finding any bleeds. They thought that they had an atherosclerotic event. Well, turns out they didn't have a stroke. There was no evidence via blood work or imaging of the brain that there was a stroke. So they diagnosed them with a TIA. Well, at this point, we are 3 years out of that event, and they still have some minor symptoms that are very similar to stroke symptoms. In reality, what happens here is you get a very small piece of plaque that barely gets lodged into a blood vessel, like you see on our diagram here, and it's barely lodged in there. So then it's essentially going to get naturally broken up by the body, or it will get pushed along until it reaches a larger blood vessel, which sometimes can happen, especially if it's barely getting lodged in the smallest blood vessel. It makes it through the capillary, and then eventually it's restored. TIA is typically treated, again, with anticoagulant therapy like heparin, warfarin. People typically are given their baby aspirin, which is an 81 milligram aspirin a day. There's been a lot of new research about that that's rather interesting and seems to indicate that only people that actually have major risk factors, major yellow flags, as they would be called, for thromboembolic events should be taking aspirin, and that there actually may not be a positive protective mechanism for older people to take it. But that is newer information and is a area that is developing in the future. One of the more interesting things that a lot of people seem to be unaware of, though, is that oral contraceptives, birth control, increases the risks of strokes. That's because estrogen actually is a very potent controller of vasculature. And the mechanisms for that are well beyond what we'll be talking about here, but I believe we'll cover it a little bit in a later lecture. Next are our hematomas. So just as they're named, epidural and subdural. Epidural is on top of the dura mater. Subdural is underneath the dura mater. Typically, epidural hematoma display symptoms quicker, while subdural hematomas can have a slower onset of symptoms. It is very possible that a subdural hematoma can present hours or even a day later, which is at that point, it can be very, very dangerous. This is why a lot of individuals that suffer trauma to their head, regardless of whether there's external bleeding, it's why they will be transported for emergency care, because you need to see if these are happening, as they can be incredibly deadly. The bleeding will increase the pressure of the brain, and it can cause all sorts of things, like causing the brain to herniate to the other side, which is nearly always fatal, and it basically increases pressure and destroys nervous tissue. So what we have here is essentially just blood vessels rupturing, specifically your meningeal vessels most of the time. One of the common treatments, since the problem that kills people is the increase in pressure, you perform a craniotomy. You remove part of the skull temporarily. Concussion. Concussion is one of the most common head injuries. It can come with loss of consciousness, but not always. In fact, we talk about how you can have multiple subconcussive impacts that can essentially result in one concussion within a short period of time. There's also something called second impact syndrome, where if you have a concussion, you hit in the head again, and you are hit enough to cause another concussion, that can actually be fatal and cause permanent damage to the brain. Typically, the unconsciousness from a concussion, though, does not last very long, and the key thing is to bring a person back to their normal daily activities in a controlled manner. What you see here, this is what would be called a contre-coup concussion. So let's just say somebody falls and they hit the back of their head on the ground. The momentum causes their brain to hit the back of the skull and then fly forward and hit the anterior part of the skull. So they can have neurological symptoms from both the anterior and posterior sides of the brain. Any part of the brain that hits the skull can have symptoms. Now, a key thing with concussion is that there is normally no imaging findings, and it is primarily a clinical diagnosis. With most brain injuries, especially trauma, if there is nothing to see on imaging, it's a much better prognosis most of the time. So a cerebral contusion is considered worse than a concussion. Think about it as a bruise of the brain. This is when you will start to see more severe symptoms. You might even find things like skull fractures, lacerations of the brain, etc. This is typically, again, same mechanism as a concussion, but just more severe. You might even see a decreased consciousness rating on something like the Glasgow Coma Scale. Full, thorough neurologic examination is absolutely necessary, and so is additional workups for the patient. So skull fractures. Skull fractures can be incredibly dangerous. These are typically associated with more blunt force type trauma. One of the more dangerous issues that can happen is if the fragment of the skull actually lacerates or gets embedded into the brain tissue itself. That can be incredibly dangerous. It can cause things like hemiplegia, loss of sensation, etc. Normally, for this treatment, they will want to make sure that there's no swelling. So they might perform a craniotomy if there is too much swelling. And if there's not, they'll do something called like a bone elevation surgery, where they pull the depressed bone or its fragments up and try to get it to reunite as it heals with the rest of the skull. So different types of skull fractures here. You can have basic linear. Depression is what we were just mentioning. Comminuted basically just means it's a multi-fragment. And then basilar skull fractures are have the potential to be incredibly dangerous. And they're one of the skull fractures that's actually associated with bleeding from the ear. So types of paralysis, what you see here, quadriplegia means no extremity movement. Hemiplegia is one side of the body is completely paralyzed, and paraplegia is the lower half of the body being completely paralyzed. So paraplegia, again, you're also going to have a loss of sensory function. Paraplegia is normally associated with injury to the spinal cord. Quadriplegia is associated with injury to the spinal cord, but it's going to be above or within that brachial plexus region, because you have motor function all the way to your hands between C5 and T1. And in fact, your hands are primarily C7 through T1 when you think about the general spinal levels. Injuries above that, like if you start to get into C3, 4, and 5, that's when you start to have issues with breathing, where the phrenic nerve is unable to communicate with the diaphragm, which, remember, is the primary muscle of respiration. With quadriplegia, you also tend to have more visceral type complaints. With paraplegia, it's typically associated with your genitourinary anatomy, where you have issues. But with quadriplegia, you start to have problems with vasculature regulation, temperature control, heart rate, and respiration. Again, it all depends on the exact level. And even within people, damage at a certain level can present in slightly different ways, because a lot of our nerves are made up of neurons that originate at different spinal cord levels, right? So for instance, we talk about our median nerve, which is typically associated with conditions like carpal tunnel. Our median nerve, the entirety of the median nerve, is spinal level C5 through T1, right? So you could have somebody with a C8 injury, and they might still have some median nerve function. Again, the degree of injury is highly variable in spinal cord injuries. The primary treatment is obviously typically going to be surgical. Like if somebody falls and they end up with something called a burst fracture, where part of the, so if I draw this out, burst fracture, so we have our vertebral body here, you have our spinous process here, and the spinal canal goes through this area right here, right behind this box, right? So we have our spinal cord. If we fall and fracture our vertebrae, we can have a part of the vertebrae collapse and crush the spinal cord, right? Kind of drew it out there. You get to push back, called retropulsion. That can crush the spinal cord. You've now damaged it. There's no signaling, right? So we can see different types of mechanisms here that result in that. This would be called this is a hyperflexion injury. So it's called typically is going to be associated with something like a flexion teardrop fracture. This is an extension teardrop fracture because there's a tear of the anterior longitudinal ligament and it's caused by an extension force. You can have actually, this would be showing a compression fracture, but the moment this separates right here and that pushes back there, that's what we're showing here, and it would be called a burst fracture if there is non-alignment of the vertebral components anymore. There are different types of spinal cord damage. You can have very minor damage. You can have more permanent injuries as well that result in major changes. Sometimes, as we see with certain sports, for instance, like football, people can have an injury and it can look like, oh my God, they're not moving, they're being given oxygen, and then they could be up the next day and be totally fine. Then there's times where, oh, that injury doesn't look too bad and the person can't walk again, right? Again, everyone highly different. Next, degenerative disc disease. So this is one of the most common conditions in the body. When the disc between two vertebrae herniates, it can then lead to compression of the nerve roots coming out of the spinal cord. This causes radiculopathy, which is the burning, tingling, numbness, shooting pain that you would get down the distribution of the nerve that nerve root contributes to. The pain can be intractable, but a lot of people have what's called directional preference, and you will see that used a lot in rehabilitation, in physical therapy, and chiropractic practices. We will utilize directional preference for a lot of good benefit for a lot of people. As people get older, though, the liquid within the disc will start to desiccate, meaning it kind of like dries up, it gets less squishy, right? You also are going to get degeneration of the vertebrae themselves. You might see facet arthropathy, which includes hypertrophy of the facet joint. You can get osteophytes, which are like bone spurs that grow out. All of those things all contribute to this. And in the worst case scenario, degenerative disc disease leads to something called spinal stenosis, which is when the actual spinal cord starts to get compressed as opposed to just the nerve roots. That results in bilateral symptoms and can cause symptoms down the entire rest of the spinal cord. So if somebody has stenosis, spinal central canal stenosis in their cervical spine, you can actually see lower extremity symptoms. And it gets very interesting because you'll start to dive into the idea of upper versus lower motor neuron symptoms. Their lower extremity would have upper motor neuron symptoms, meaning it's on its surface, it looks like it's a brain injury. But when you piece together the idea that you have lower motor neuron symptoms in the upper extremity, you know the problem's actually in the cervical spine, and it's just causing problems down the line. Degenerative disc disease, one of the most common drivers of this condition is actually lifestyle, not exercising enough, obesity. In fact, in general, obesity is bad for everything. When you are overweight, the body has lots of triglycerides. Triglycerides adipose tissue, adipose tissue loves to make inflammatory cytokines, and not the good kind that control inflammatory. You get lots of things like interleukin 6. Interleukin 6 is horrible for inflammation. It ramps up inflammation. And we also see issues with like omega-6 fatty acids building up inside of joints, not just your your vertebral joints, but also joints like the knee, the shoulder, the hip. And those things cause inflammation themselves, and it leads to breakdown of cartilage, and it's not very good. In fact, diabetes is also linked to degenerative disc disease via a special substance called CAMP. And CAMP is it's related to some energy signaling. And long story short, they're actually starting to use metformin, which is one of the non-insulin diabetic drugs, to treat osteoarthritis, which is essentially degenerative disc disease. But degenerative disc disease is just degenerative joint disease of the spine, because we're being more specific. So you'll often see osteoarthritis, degenerative joint disease, degenerative disc disease. Those things can all kind of mean the same idea, but it's this process that really is rooted in poor inflammatory control, which is why NSAIDs can work very well. Steroids can work very well. The direct injections on nerve roots work very well. And as an absolute last resort, if the degeneration is bad enough to cause what we term myelopathy, which is basically damage to the spinal cord, you can get surgeries in order to do things like shave off osteophytes, do fusions in order to prevent the progression of antero or retrolisthesis, which is the sliding of vertebrae on top of each other, etc. TENS. Talked about TENS shortly before, but the idea is you're using the gate control theory of pain, meaning we're providing a fast signaling nerve response via the TENS unit. It's a electrical signal directly onto the body, and we are overriding our slow pain signaling neurons. Slow pain is that burning type pain, and fast pain tends to be sharp and stabbing. So regardless, if we can give the body a sensory stimulus that travels faster than the pain stimulus, like TENS will, we can actually trick the thalamus into ignoring the pain signals from that region of the body. That is the whole basis of the gate control theory of pain. And a lot of pain-based rehab actually relies on that. A lot of stuff in physical therapy, occupational therapy, chiropractic, etc. We do tons of things in that field to utilize the gate control theory of pain for our benefit. TENS is great though, because you can use TENS all day long, and it's done a lot of great things for people that are in extensive pain. The big problem is though, certain patients can't use a TENS unit, like individuals that can't feel pain, you shouldn't use a TENS unit. Individuals with pacemakers or other electrical type of implants, they should not be using TENS units, because those could interfere and cause a problem. Next, herniated bulging disc. These are actually two completely different things. Bulging disc is actually relatively normal, and so can herniation. In fact, there's plenty of studies that exist that show even people in their 20s regularly have herniated discs that are asymptomatic. Now, if it's symptomatic, it is a problem. Now, a bulging disc is something that is completely contained, okay? You're not getting direct pressure onto the spinal cord. There could be inflammation, so chemical pain that gets caused by a bulged disc, no problem. Now, herniations come when the disc is being less and less contained, and there's different types of herniations, with extrusion and sequestration being the worst part. Sequestration basically means that if we were looking at this example here, we said this uncontained part of the vertebrae actually got pulled away from the rest of it, and it was freely floating. It could do whatever it wants, including start crushing the spinal cord here. Those types absolutely need surgery. But in a case like we see here, it's starting to push, and it could migrate, while still attached, migrate a little up or migrate a little down. That's what's called an extrusion. Typically, patients that have that may or may not need surgery. It depends on the person. So again, you're seeing here from a lateral view, herniated disc, essentially starting to extrude out, putting pressure on the cauda equina of the spinal cord because this appears to be a lumbar vertebrae. But ultimately, there are lots of treatment options for it. Conservative care can work very well, especially for lower grades. But again, surgical options do exist for people that have high grade, intractable pain from these. Next, sciatic nerve injury, spinal stenosis. These are actually two very different things. We already talked about spinal stenosis before, but that's just a narrowing of the canal, right? You can have central spinal stenosis or foraminal spinal stenosis. Foraminal spinal stenosis is going to be that compression that we talked about before, where you get compression of the nerve roots leaving the spinal cord, whereas central canal stenosis is compression of the actual spinal cord in the canal itself. Sciatica is that stereotypical pain that you can get in your low back that radiates down the buttock, down the posterior leg, and true sciatica actually goes beyond the knee. Now, you can have nerve pain above the knee, don't get me wrong, but there are plenty of other things that actually cause pain in that region that's above the knee, and it can be incredibly tough to differentiate it out. You can have muscle pain from muscles like the piriformis. Your SI joints, your sacroiliac joints, can refer pain all the way down to the posterior knee. You can get other types of muscles that cause pain. Hamstrings, for instance. You could have a hamstring injury, and inflammatory mediators close to the sciatic, if you have a ton of inflammation near the sciatic nerve in the periphery, it can cause the nerve to be sending inappropriate signals like burning, tingling, right? So it takes a skilled diagnostician to pull these things apart, which is why history exam are so important. Big thing for treating of spinal stenosis, specifically your foraminal stenosis, your sciatic nerve injury, any other type of radiculopathy, right? Rehab is a great thing. Another thing that also works very well medical-wise is we'll use medications like gabapentin, which help shut down pain signaling. There's Medrol packs, which are just oral corticosteroids. Now, the slide says narcotics, but they typically do not like to give narcotics for nerve pain. Narcotics are not that effective for nerve-based pain in the periphery. But they can work for some people. But there's a lot of evidence that for nerve-based pain, ibuprofen combined with Tylenol is actually just as effective as low-dose narcotics. You can also have a decompression type surgery. If it's a central canal stenosis, they'll remove whatever's causing the pain. If it's a foraminal stenosis, they do the same thing. That might involve putting in a surgical hardware, but it all depends. Headache. Now, there's multiple different types of headaches. Most common term scientifically for headache is cephalalgia. So headache is a widespread thing, lots of different causes because, again, there's different types. You can have cluster headaches, which are associated with pain behind one eyeball. They're abrupt. Sometimes they happen around the same time of day. And for a lot of, if a man has cluster headaches, it tends to be associated with the consumption of alcohol, right? The kind of headache that's associated with a hangover. It can happen in women too, but males are the larger population to be alcoholics. Headaches can also be caused by underlying diseases and other bodily processes. It's actually very normal when we speak about normal bodily processes. Like I mentioned before, estrogen, massive controller of vasculature, right? Well, there are headaches that happen during the monthly cycle of females, right? It is possible to have hormonal headaches. The big thing to remember is headache is typically always associated with some underlying cause that's changing vascular structure. One primary cause of headache, though, that is often overlooked is what we call a tension or cervicogenic headache. Now, the International Headache Society has debate over whether these are two separate things, whether they should be classified together. Ultimately, it doesn't matter. You have muscles causing the pain, whether it's from your cervical musculature or your facial musculature. Now, when we talk about cervicogenic component of it specifically, we have a set of muscles in the posterior part of the spine. These muscles are called your suboccipital muscles. There are 4 of them. Two of they're associated with the occipital bone, your C1 vertebrae, and your C2 vertebrae. Well, within this area is a little region called your suboccipital triangle, and I can draw this out real quick. So you have a muscle here, a muscle here, a muscle here. You have a nerve that comes out between these muscles, right? That nerve can get irritated by the muscles, especially if you have hypertonic musculature. You get trigger points, you get all kind of nasty stuff happening within this triangle. That irritates this. Well, what happens is this nerve is actually integrated with something called your trigeminal nerve. Trigeminal nerve is your fifth cranial nerve, and the trigeminal nerve is responsible for providing sensation to your face and part of the top and anterior portion of your head, as well as your jaw. It's also related to taste in a little ways, etc. So those nerves actually integrate together within the brainstem. If you have too much irritation of your C1 through C3 sensory nerves, you will actually get irritation of your trigeminal, which is why you get headache-like symptoms. It's pain along above your ear, behind the ear, and it can wrap all the way up along your temporal region of the head towards your eyes, right? If it's caused by these muscles, it tends to only happen on one side of the head, but you can also have it bilaterally because, again, these muscles exist on both sides of the skull, and you have your C1 here, your skull's here, and your C2 spinous process is here with your C1 posterior tubercle there, right? So, and there's actually a fourth muscle, your rectus capitis posterior minor, in that I just drew there, but that muscle is kind of useless. But you would treat, these things like any other muscular problem, even though they cause a headache. Migraine, though, on the other hand, is a little bit more severe. The exact cause is unknown, but it's related to two things. What's called cortical spreading depression, which is abnormal increased signaling of neurons, overexcitation, and that leads to vasculature changes. Now, what comes first isn't necessarily fully understood, and why it's caused, etc., isn't fully understood either. But we do know that migraine is related to something called CGRP, which is a calcium-related molecule, a receptor specifically of a calcium-related molecule, which is why typically we use CGRP-related drugs to treat migraines. You can also take drugs related to vasoconstrictors. Some people typically have migraine triggers. They might even experience something called an aura. So they might start to experience symptoms before the pain starts. And in those patients, it can be highly effective to use what's called a rescue medication, something like Neurontin, to help potentially prevent the migraine from starting. Some people, though, they might just need to take a nap, sit in a dark room, avoid light, sounds, etc. Other people's breathing exercises work really well. Some people, though, they're triggered by food. They're triggered by not eating food. There's medications that can cause it. Everybody's different, but overall, when we talk about true migraines, it typically is females that experience the most true migraines, which again comes back to the idea that estrogen is a huge driver of changes in vasculature. Epilepsy. This is seizure disorders. This is overactivity of the nervous system. Uncontrolled overactivity. We have different types of seizures that exist. That's well beyond what we need to know, but you can have your tonic-clonic type episodes, which are like the shaking. You can have what's called like absent seizures, where somebody just stares off into space and doesn't realize that something was going on. That was a petit mal. That's what's called petit mal, whereas your full-on shaking typically is called grand mal. Big thing with epilepsy, never stick something in someone's mouth, right? The big thing is make the environment safe, move stuff out of the way, and go from there. Again, first aid for seizures, rescue position, remove anything around the neck, look for an ID. If somebody has a seizure disorder, they might have a specialized ID for them. Typically, if the seizure doesn't last too long and the patient comes to, you might let them decide on if they're going to receive medical care or not. But if the seizure continues typically for over 2 to 5 minutes, then you want to call 911 at that point, especially if the person is not known to have a seizure disorder. Next, Parkinson's disease. So Parkinson's disease is a progressive neurological disorder. It's typically associated with poor coordination, and this is because it's caused by degeneration of the dopamine-producing neurons in the basal ganglia, which, remember, the basal ganglia are part of the thalamus. Specifically, the basal ganglia that starts to degrade is something called the substantia nigra. It's called that because the neurons in that region are a very dark color compared to the neurons around them. I'm not sure why that is. I'm sure there's a reason for it, but those neurons are one of the primary locations where dopamine is made. Dopamine is important for signaling our cerebellum, which the cerebellum helps with coordination. In fact, the cerebellum is an inhibitory area for motor, meaning it actually reins in our motor function. Incredibly fascinating system, and more is being discovered about the cerebellum every day. The fact that it has roles in learning, etc. What actually causes these degenerations? Very unknown. But as we mentioned in a previous lecture, there's actually evidence that with Parkinson's and dementia, some of the initial symptoms might actually be a loss of smell as early as 10 years before symptoms start. Now with Parkinson's, two of the big common symptoms you start to see is muscle rigidity and what's called a pill rolling tremor, where the person's kind of moving their wrist in a circumducting type fashion with their thumb and forefinger together. Other kind of things is you see a slow shuffling gait that slowly gets quicker as they move, and they might have postural instability as well. So the patient typically, when they start to get moving, their feet don't take very large steps at first. It's more of a shuffle. They lean forward to help build momentum, and they actually will start to gain speed as they get forward, especially in the moderate stages of the disease where they can still walk, but they are definitely affected. There is no way to cure it, but there has been a new treatment called deep brain stimulation, where they actually place electrodes on the skull and provide electrical impulses to the brain to help stimulate the brain to work properly. There are a lot of passive treatments for the condition as well, like physical therapy and occupational therapy to help the person maintain quality of life as long as possible. And a lot of the medications that are used are typically related to maintaining dopamine levels. Like they're essentially dopamine agonists, dopamine receptor agonists. Their entire thing is to help stimulate dopamine and dopamine receptors. Huntington's, it's a hereditary degenerative disease of the cerebral cortex and the basal ganglia as well. And you see lots of atrophy of the brain. Now, family history of Huntington's is one of the most important ways to diagnose it. We don't exactly know why it happens, but we do know that there is a defective gene, but the specific gene is still largely unknown. There's quite a few candidates available. But chorea is essentially the idea of uncontrolled flailing type movement. So someone with Huntington's could be sitting completely still and an episode of chorea hits and they start to swing their arm around, right? It can be incredibly disrupting for people's lives because they can't sit still. A lot of these people eventually can't hold a job. The big problem with a lot of these people is they almost essentially start to get stuck inside of their body. And it's incredibly unfortunate because their body ultimately stops listening to what they want. Treatment is generally just supportive and based on symptoms. There are drugs like Haldol that can be used to reduce the choreic movements, but again, it's all supportive. So ALS, amyotrophic lateral sclerosis, which is typically referred to in like the media as Lou Gehrig's disease. It's a destructive motor neuron disease resulting in atrophy of the muscle. So only motor neurons are affected in here. If we talk about the other major nervous system degenerative disease being multiple sclerosis, MS, that affects everything, all right, sensory and motor. ALS is motor only. Eventually, it results in people being unable to walk, and they need a ventilator. They can't chew, they can't swallow. It's incredibly progressive, and the progression can vary a lot. The big thing to worry about in these with a new patient that you're suspected of having it is having no sensory deficits despite having upper and lower motor neuron involvement. This is going to be, again, a multi-provider treatment led by a neurologist. They use drugs like tizanidine and baclofen to help, and a lot of symptomatic-based drugs. They help to help the person with pain, to help them with sleep, to help them with fatigue. Eventually, they'll start having issues with excess saliva, and there's also treatments for that. Restless leg syndrome. So this is a condition related to overwhelming urge to move the legs, just like the name says. This is actually generally thought of to be a sleep-related disorder. Patients often describe like burning or jittery feelings in their legs all the time, and they feel like they have to constantly move. It interferes with everything in their life. And it doesn't have to be relegated to just the legs. Patients can have this symptoms in, their arms, their face even. It can be incredibly disruptive. Interestingly, there is some evidence that iron levels in the blood could be related to it, but again, there could be multiple underlying things related to it. Typically, the symptoms do worsen as you age, and you really need to consider the psychosocial impact on the person. Next is transient global amnesia. It's considered global because it's going to encompass a patient's entire memory. They won't know who they are. They won't know what's going on. They're going to repeatedly ask you, where am I going? What are we doing? Why did we do this? They can perform their normal tasks, though, without problem. Eventually, though, the prognosis is pretty good. Typically, they come back and they're healed. That's why it's called transient. And recurrence is also very unlikely with this condition. It's incredibly fascinating. We have no idea about it. Next, neuropathy or peripheral neuritis. That's degeneration of the peripheral nerves. There's multiple things that can cause it. Things like chronic alcohol intoxication, which is related to B12 deficiencies, like we talked about before. You can also have heavy metals like lead and arsenic. You can have the inflammatory arthropathies that we talked about before. Conditions like gout, rheumatoid arthritis, lupus can all cause neuropathy. One of the most common reasons for neuropathy, condition that's incredibly common now, and almost 50% of Americans now can be diagnosed with it, is type 2 diabetes mellitus. Glucose, high glucose being the cause of diabetes, type 2 diabetes, I should say, and all the things that come with it. Well, glucose is actually neurotoxic. It's a neurotoxin. It damages nerves, damages blood vessels. So not only are the nerves not getting nutrients from the blood vessels, but the glucose gets in there with the nerve and it damages the nerve. It's not a good thing. That's typically associated with findings in the lower extremity at first, but in really bad cases, it'll affect hands, and people in severe cases end up with the more systemic effects where you get the full vasculature problems, etc., and they have to have amputations. Treatment: you remove toxic substances if they're there. Nutritional and lifestyle counseling, treatment of underlying diseases. Typically, neuropathy is not something that's going to just happen on its own, right? You can also use drugs like antidepressants, which are relatively helpful for people avoiding the chronic adaptations to the brain with pain. But it is, and gabapentin can also work well for these patients. Trigeminal neuralgia. So we mentioned the trigeminal nerve before. And in fact, I'm going to come to the next slide to show you a diagram of it. The trigeminal nerve has three primary branches: your ophthalmic, maxillary, mandibular. The mandibular component is the only component that is motor, right? And that controls your muscles of mastication, which is chewing. That's your temporalis, your lateral and medial pterygoid, and your masseter muscle. All of those things involve moving the jaw up and down in order to chew food. With trigeminal neuralgia, you're having pain in the trigeminal nerve. It's often excruciating. It is intractable, meaning we cannot get rid of it. And in fact, it is so bad in these people, it's called the suicide disease. So many people will actually commit suicide with this condition. It is incredibly painful. It's not fun. It's not good. You might hear it called tic douloureux. I'm sure it's French. I don't know where it's from, but I do think that there are still some older providers around that still use that term. But trigeminal neuralgia is a much better descriptor. Muscle relaxants could work, but ultimately the general cause is unknown. But things like your herpes viruses can actually cause it. Herpes will live in nerve roots. Well, if you get herpes zoster or shingles in your trigeminal nerve, you can end up with this, especially when the virus is active and there's a flare-up. All right, so Bell's palsy. This is another cranial nerve disorder. This time, though, it's for the facial nerve, which is your 7th cranial nerve. That nerve controls motor to your muscles of facial expression. So with Bell's palsy, like this picture shows, you get drooping of the eye. You can't wrinkle the forehead, or sorry, not drooping of the eye, but the eyelid can't roll up. You get paralysis of the face, essentially, on only one side. This is something that has to be differentiated from a cerebrovascular accident. It can look very much like a stroke, but as we talked about before, arm and speech for stroke. If a person is able to talk and understand language completely fine, and they are able to move the rest of their body completely fine, stroke is a lot lower down the differential. Typically, though, Bell's palsy is associated with things like viral infections. They like to do a lot of facial-based exercises. Occupational therapy can be great for this type of stuff. Analgesics. You might need temporarily artificial tears because your facial nerve actually helps innervate the lacrimal gland. And you might need an eye patch as well. So again, with Bell's palsy versus trigeminal neuralgia, there is no pain with Bell's palsy, as it's a motor disorder, whereas trigeminal neuralgia is a sensory disorder. Next is meningitis. So meningitis is inflammation of the meninges, which are the layers, the membrane layers that cover the brain and spinal cord. The big symptoms of meningitis to think about are things like vomiting, headache, and what we call nuchal rigidity, which is the inability to move the head very much, and it would be incredibly painful. This is why you end up seeing signs like Kernick sign or Brudzinski sign clinically, where you're putting tension on the meninges, and it actually causes the patient to either flex their head or bend their knee, as that's going to reduce as it becomes painful, and so the patient reacts by moving those areas as you tighten down on the meninges. You can see lots of different symptoms from this. And there's different types of meningitis. There's bacterial, there's viral. There's going to be different findings in like the CSF fluid, in blood labs, etc. Treatment, if it's bacterial, you're looking for antibiotic therapy. Patients can have seizures, so you're going to want to treat based on that. Corticosteroids, specifically glucocorticoids, are very good for inflammation in the brain. And really the patient just needs a good amount of rest. Encephalitis now is inflammation of brain tissue itself, typically associated with a virus. Chickenpox, measles, mumps. There's other things related, like there's like Japanese encephalitis and other stuff associated with like mosquito bites. You're gonna again get stiffness of the neck, weakness, restlessness, visual disturbances, tiredness. Typically, we use antiviral agents if it's a herpes-based virus, anticonvulsants, treat symptoms. in areas where viruses that are common to cause encephalitis are, there are some vaccines for certain types, like the Japanese encephalitis. I was vaccinated for that before I moved to Japan as a child. There are some prophylactic treatments for it, but not all the time. Prognosis, though, is pretty unpredictable. Depends on the person and how quickly they receive care. So Guillain-Barré symptom. This syndrome is a very interesting case. So the person actually experiences what's called ascending paralysis. So typically in the hands, but it can start in the feet too. You start to get numbness, tingling in the feet, muscle pain, paralysis, and it ascends. So rather than most paralyses that we experience being a descending cause, where it goes from your brain or spinal cord and out, Guillain-Barré starts in the hand and works proximally. So it is progressive and it moves up the body. There is an autoimmune component to it, and it is associated with viral infections a lot. Hospitalization is pretty much always required. Prognosis can be good. Recovery is typically complete, which is great, but it can be a very scary condition to have. Some people can end up in a bad enough situation where they need like ventilatory support, etc. But it can be very self-limiting as long as you have that supportive care while hospitalized. Brain abscesses. Oh, and one more thing to mention about it is that this is one of the big cases with viral insults. For some reason, there is a response that our body does to viral infections and other types of viral insults, such as like vaccination for a virus, that actually ends up being theorized to be related to the cause of this. But again, viruses are the primary reason that this occurs. And normally a virus itself causes Guillain-Barré to be much worse. Brain abscesses. So this is just an infection within the brain. It's a collection of pus, essentially, that's contained within the brain. Patients are going to get symptoms dependent on where this is at. So if it's primarily in the frontal lobe, you might have issues with higher order functions like speech. You might have issues with movement. You might have issues with coordination. If it's in the occipital lobe, you could have issues with vision, temporal lobe, hearing, etc. Because the different lobes and association areas of those lobes are associated with different functions. This can be a local infection, or it could be an infection that actually spreads systemically. So what you just see here is a quick diagram of one that's going to be somewhere between the mid coronal plane of the brain. Typically, though, bacterial infections in the brain are associated with direct inoculation of an organism. So some sort of penetrating trauma, and it doesn't necessarily have to occur in the brain, because your spinal cord, via your subarachnoid space and the cord itself, is actually connected to your brain. There is circulation that goes through there. So you can end up with that. You can also get hematogenous spread, meaning you could have an infection from somewhere else. It spreads through your blood. And then there's otitis media. It's not very common, but because infections of the middle ear, especially in children who might not have the most developed immune system, it's so close to the brain, it can spread through tissue that way as well. Treatment, IV antibiotics. If it's not controlled, the pressure of the brain's not controlled, death is very likely. You could have herniation of the brain across the midline, which is pretty much always fatal, as mentioned before. You might need a surgical drainage of the abscess or something like a craniotomy to help relieve pressure. Now, poliomyelitis and post-polio syndrome. Polio, is a viral infection of the anterior horn cells of the gray matter of the spinal cord. So I'm going to draw this out real quick right here. We have our spinal cord, right? Let's do away with this. I'm going to draw it a little differently. So we have our spinal cord here, okay? Drawing the butterfly-like shape of the spinal cord. right? And we have our central canal here. Where the arrows are pointing, that's your anterior horn cells. Those are motor cells, okay? Back here is your sensory tracts. They come in that way. So polio affects these motor cells, which is why you get the motor type symptoms. It destroys motor neurons. Polio is a relatively eradicated disease in the developed world. There are a couple areas of the world that, for various reasons, are still experiencing polio epidemics. It's primarily related to religious regions, things like that, distrust of the medical environment. Typically, we're seeing it in certain regions of like very remote countries like Afghanistan. I think there's a couple African countries that occasionally get cases. And then you occasionally get the random case here or there, like the one that potentially is several people in like the New Jersey, New York area that we saw last year as they discovered the poliovirus actually in the water treatment samples. What you get, though, is progressive muscle weakness. You get your nuchal rigidity, nausea, vomiting, and you end up with what's called flaccid paralysis, meaning the muscle will not contract because there's no nerve impulse to it, as opposed to something called like a rigid paralysis, where the muscle is fully contracted and won't uncontract, almost like a tetanus. Typically, though, the poliovirus is inhaled via our mucous membranes in our mouth and nose, crosses through our gastrointestinal tract, and reproduces in lymphoid tissue. There are different types of the virus. None of that's important. All three types are worldwide, and the immunizations that exist are pretty much 100% effective for all three forms. Anybody that's immunosuppressed, though, is highly susceptible to something like poliomyelitis. Now, one of the more interesting aspects of polio is that someone can contract polio, completely recover from it, live a normal life. 20, 30, 40 years down the line, they start to experience paralysis in a limb. That is post-polio syndrome. What happens is a lot of our muscles are actually innervated by multiple nerves. And with polio syndrome, if you get enough destruction of certain anterior horn cells, you actually have destruction of many potential nerve roots that contribute to one nerve. Well, eventually, as we go through our life, that nerve might, become damaged from other things. It starts to degrade as we get older, and that nerve stops working as effectively. It was not fully functioning after polio because it was, essentially permanently damaged, because those anterior horn cells are motor ganglia. Once the ganglia itself is damaged, the neuron pretty much can't be replaced. So then you get another nerve kind of helping stimulate that muscle. Well, eventually nerves get tired, they stop functioning right, they start to degrade, and now, because of the polio destroying some of these anterior horn cells, and you get your natural age-related degeneration of the body, you now don't have enough neurons stimulating muscle. And that muscle essentially becomes at least partially to fully paralyzed, and that's post-polio syndrome. Not everybody gets it, so that's a completely different thing. But it is relatively common enough to be something that we need to consider. Now, brain tumors. There's different ways to classify brain tumors. You can talk about intracranial ones. You can talk about ones that are extramedullary, intramedullary, cortical, etc. There's all kinds of classifications, but these can arise from any cell type within the CNS. They're typically named based on the type of cells, like a glioblastoma are associated with glial cells. Meningiomas are meningeal cells. Schwannomas, Schwann cells. You can get neurofibromas, which are nerve sheath tumors. Anyway, symptoms are the primary result of displacement and compression of tissue, and can also be related to the fact that you have now different or non-functioning brain tissue replacing functioning brain tissue. It's very important to have histology for treatment of any cancer, but especially nervous system cancers. One of the most concerning signs that we see is in young people without a previously diagnosed seizure disorder starting to develop seizures. One of the top differentials at that point, especially if somebody's in their 20s, is immediately imaging. Do they have a brain tumor? If somebody is, realistically 30 or less, never had a childhood seizure disorder, and they suddenly start developing seizures, you need to rule out brain tumors. Interestingly, brain tumors are more common in the quote-unquote developed world. There's likely environmental reasons for that, environmental and lifestyle. Showing here is a brain tumor. It looks very much like an abscess. Conceptually, kind of the same, except for instead of bacteria, we get increased intracranial pressure because there's a mass pressing everything away. This right here shows herniation of the brain across what's called the falx cerebri. So when we're looking at our skull, we have these dural reflections. So our dura mater folds over on itself, and the one that runs anterior to posterior along the top of the superior portion of the skull is called the falx cerebri, and it helps divide our left and right hemispheres. And if there's enough pressure under one of the hemispheres, this is that herniation that I mentioned before. It pushes through, and all of that tissue in here is dead, essentially, at that point. The bigger the herniation, the less compatible with life. Most herniations are pretty significant as they involve rupturing of the falx cerebri, and they're pretty deadly. You can also, though, get cerebellar herniation. This can cause that Chiari malformation that we talked about earlier, but this is slightly different. So again, you need a detailed history, neuro exam, and diagnostic neuroimaging studies, preferably read by a neuroradiologist. Tumors in the brain can be malignant or benign, but in reality, just about any space-occupying mass in the brain can be incredibly dangerous because of its ability to compress tissue, whether it's malignant or not. So treatment of primary tumors, you're realistically looking for surgery, radiotherapy, chemotherapy, immunotherapy. It depends on the type of tumor, where it's at, etc. The key thing, though, unlike the rest of the body, benign and malignant tumors tend to be treated the same because of the fact that benign tumors tend to increase cranial pressure. Secondary tumors, these are metastatic. They're coming from other places, okay? This is primarily going to be tumors like lung cancer, kidney cancer, breast cancer. Those are three, and even bone cancers. Some of them will metastasize to the brain. The main thing with metastasis is you try to treat the initial primary lesion, but you also do typically need radiation of the brain as well. Brain tumors, survival rates are unfortunately pretty low. The 5-year survival rate for adults is 30% or less, which right here we have 32%. But it is a little bit higher for children, primarily because of the types of tumors that develop in children. But with children, you have to consider things like developmental disabilities once these tumors exist, as they have displaced or damaged normal nervous system tissue. So, if you guys have any questions, that's everything for the neurological conditions, chapter 13. If you have any questions, just make sure to ask.